joining us for this webinar today. I'm very happy you could join us and hope you guys enjoy it. I'll do a short introduction, but a couple housekeeping things just for everyone that's on. If you could take a look to your right, I think it's your right on the screen, it's on my right. You'll see a chat feature. If you have any questions at any time during the webinar, please enter them there. We will definitely review them at the end. If they fit in with the conversation that's ongoing, I'll sort of monitor that and do my best to sort of insert them with our panel during the conversation, but otherwise we will hold them to the end and allow everybody to comment at that time. So as you know, this is a pediatric sort of focused webinar on sort of the implications and interactions with the new ASA neuromuscular blockade monitoring guidelines. I'm very pleased to introduce our panel today. I'll start with Dr. Soren Bruhl. Dr. Bruhl is an emeritus professor of anesthesiology at Mayo Clinic. He's going to serve as our moderator today. Dr. Bruhl's been doing this for a long time, a lot of neuromuscular blockade monitoring and research. So thank you, Dr. Bruhl, for joining us and doing this today. In addition, we have Deb Falk. She's the associate professor of anesthesiology at Children's Hospital in Colorado. Thank you, Deb, for joining, and is definitely done some research on this in the past, and wonderful to have her on board. And then also we have Dr. Joe Tobias. He's the chair, Department of Anesthesiology at Nationwide Children's Hospital. Thanks for joining us, Dr. Tobias. Appreciate it. Known Dr. Tobias for quite a while, and appreciate him taking the time to do this. So again, for those of you just joining us, put your questions that you have during the topic in the chat. We'll make sure to get to them at the end, or get to them, all of them that we can. And again, thank you so much, everybody, for joining. We did have one other speaker that was going to be joining us. Dr. Myron Yaster actually got summoned to jury duty yesterday. So he was unable to join us. He really thought he wasn't going to have to do it, but turns out he did have to do it. So he will not be joining us today, unfortunately. So, but we have a very good panel. And Soren, I'll kick it off to you to get started. Thank you so much, guys.
All right. Thanks very much. And thank you, the panel, for being here. By the way, I told Myron that I would be happy to trade places with him and go jury duty if you wanted to participate, but he declined. Anyway, it's wonderful to have the two experts with us. I haven't done pediatrics in many years, and I think it's particularly important that we discuss the topic of neuromuscular block management and monitoring in pediatrics. Because I think that has not been a real area of focus. So I would just like to ask the panel, in light of the ASA guidelines in adults that were just published, how have these guidelines altered or changed your practice in any way? Deb?
I was really excited when those guidelines came out. I was a little bit sad to see that kids weren't included, but I guess that's not too surprising. But my practice was transitioning to quantitative monitoring even before the guidelines came out. And I think that a lot of what I was trying to accomplish in terms of maybe bringing some of my colleagues over to the dark side who were really resistant. I was excited to see those guidelines come out because I think it's just one more piece of information and reminder that this is an important thing for us to do, and it really can help us keep our patients as safe as we possibly can.
Yeah, I totally agree with Dr. Falk. One, I think it was great to see the guidelines come out. Again, it's always discouraging, but I think it always happens that we have guidelines for adults, and then I'll bet you, sometime in the future, we're going to write our own for the pediatric population. And I think it did, get me interested in quantitative monitoring, because I'll have to say that, I hadn't been using a lot of monitoring of neuromuscular block in my practice. And we can talk about why that is over the course of the next hour. But, I think part of it was I'm a huge user of Sugamidex. I believe in that drug. So I think it made my practice a little bit sloppy sometimes. But I think the guidelines were helpful. I think it reminds me we've got probably thousands of papers to write in kids to look at how we monitor neuromuscular block. And I have to thank Dr. Brule because he's taught me that it's neuromuscular block and not blockade. So if I say blockade, you'll have to excuse me, but I'm really working on it because I've read your papers for my entire 34 years of anesthesia. So I appreciate that. But I think it's there's so much research we need to do. How to monitor, what are the best monitors, which scenarios we monitor. And then I think the really important one is to look at outcomes in patients who are not fully reversed. And I think we really need that in pediatrics. Obviously, a lot of years to go, hopefully still in my practice, and maybe a lot of work still to do in this area. So I think the guidelines really got me interested in this field.
Yeah. But why do you think that we need guidelines in pediatrics? Because pediatrics is just small adults, right?
Joe, you want to take that?
Yeah, I've heard this for 40 years that, pediatrics is not just small adults.
Right. So. No, I think, I'm going to be the first one to say if I'm taking care of a 30 kilogram patient having an orthopedic procedure, that probably is just a small adult coming to my pediatric ORs. But I think, as we've looked at quantitative monitoring, it's really shown me that, I was always taught, or maybe I had learned or accepted that, this patient's 10 kilos. I can't monitor this patient's block, and, the patient's 8 kilos, this isn't going to work. But as I've used some of the new EMG-based technology, it's amazing. Some of these devices will work in even some of our smaller patients, and I think those may be the ones that are at the greatest risk. Even what we may consider a simple pyloromyotomy, I think given the duration of neuromuscular blocking agents in that population, altered metabolism, I think it'll be exciting to see how some of these monitors work in smaller pediatric patients, the ones that aren't just little adults.
Yeah. So sorry, Deb, go ahead.
Well, yeah, I just think that, for any monitor that you use, you have to understand or think about what it is you're trying to accomplish. And even though older children, teenagers may be physiologically kind of like small adults, that doesn't mean that they're at less risk than an adult of having issues with residual block on board. And so the guidelines clearly point out, I think, that risk and the benefit that you get with a quantitative monitor versus a peripheral nerve stimulator or, God forbid, doing nothing. And so I think it's just as important in those patients to think about monitoring. And I think that the real money is in the smaller children. I think it's especially important in them because of the physiological changes that they go through during development that may put them at greater risk of potential bad outcomes or adverse events if they have residual weakness. So, as Joe says, I think there's a lot of work that needs to be done in this area. But as with any population, I think ignoring the potential for adverse outcomes just because it's a healthy adult or it's an older kid, I think we have to steer away from that as well. That kind of makes me think about, when I was training and we would write notes and the shorthand, if everything was normal in their review of systems, the shorthand was WNL, right? Within normal limits. And we joke about it and say, well, it's because we never looked. And so trying to steer away from the WNL and quantitative monitoring and neuromuscular block, I think, is something that we have to think about.
No, that's thank you. So, if we do agree that quantitative monitoring is just as important for pediatrics as it is for adults, and I think that we do, and one can make a case that it can be even more important, what specifically what information do you specifically want to get when monitoring? I mean, are you looking at adequacy of intubation, at redosing, at D-block, recovery? What do you think are the real important key points in pediatrics as opposed to adult population?
I think all of those are key points. Your focus on which of those might be more important for you at any given point in time may shift depending upon the patient and the surgery that they're having. A small child or baby might be easy to intubate without any relaxation, just because they don't have that muscle tone that might make it difficult to intubate in terms of intubating conditions, but they may be having a procedure that's really, really important for them not to move. So, one thing I think about is we do a lot of kids who have retinoblastoma, and we do intra-arterial chemotherapy to the tumor. And I may be able to intubate that child without any difficulty just using some propofol and some fentanyl, and they're relaxed and anesthetized deeply enough for me to do that. But if they move at all when that catheter is in place and we're injecting that chemo, that's a really, really dangerous point. So those kids are all paralyzed for the case. And I think that just depending upon where you are will dictate where it's really important for the type of monitoring that you're going to be doing, and your degree of frequency of that monitoring.
Anything else you want to add?
Yeah, I mean, I would say that, yeah, I agree 100%. And also, I think it just depends on the clinical scenario. I mean, for a rapid sequence intubation, I like to see that the neuromuscular blocker has kicked in and we're ready to do our laryngoscopy. If I'm doing repeat dosing of a neuromuscular blocking agent, I like to know when. So especially in the younger patient, when the metabolism is varied, I think a monitor can tell you, hey, it's time to redose. And I think one of the interesting things in my years in practice is we've started using a lot more continuous infusions of neuromuscular blockers in the operating room because of the complex types of surgeries we're doing, some of the neurosurgical procedures, the robotic cases, like Dr. Fox said. Some of these, you don't want your patient ever even thinking about moving. And yeah, it's not a big deal. You can certainly intubate them without a neuromuscular blocking agent, but man, you need that patient. You need to ensure that, maybe you've got one twitch of your train of four so that the patient isn't at risk of moving. We're using continuous infusions. So I think these quantitative monitors help us guide those infusions, which, I find to be the requirements to be incredibly variable. Based on the comorbidities of the patients, the medications they're chronically ingesting, and so many other factors that, there's probably a 5 to 6-fold variability in infusion rates that we've seen in some of those cases. So again, I think, monitoring in those scenarios is important.
So this is interesting because both of you have said that intubating without a muscle relaxant in pediatrics is really not all that difficult. There's quite a controversy, at least in adults, about, we can use Brutane and hold them down and intubate. But the question is, it's not just, perhaps, at least in adults, it's not just the ease of intubation. It's also protection of the vocal cords and pharynx and all that. Is that an issue? I mean, in pediatrics with potential vocal cord injury or other injuries, when you're trying to put that, granted very small tube, but through those closed vocal cords?
Yeah, I think that, for kids, I think one of the benefits that we have versus care in adults is that most kids go to sleep breathing gas. And so we have the extra added layer in terms of the depth of their anesthesia once we go to instrument that airway, that most likely they're not going to react to that instrumentation, whereas adults, all they get is a slug of propofol. And if you're going to give them enough propofol to make them quiet enough to do a direct laryngoscopy, you're probably not going to have a blood pressure anymore. So, so I think that is one advantage that we have. If you're not deep enough, will the patient buck, and will you be at risk of complications? Absolutely. And so, at least for me, in my practice, when I have older school age kids or teenagers, that's when I'm probably going to reach for some rocuronium to make sure that they don't cough or buck against that, outside of the other indications that we would have, like rapid sequence induction in any age group. But absolutely, you can see those things. So we have to think about when it's appropriate or when it could be excluded.
Yeah, I would agree. I think, again, it's a lot judging the clinical scenario. And, I mean, I can have a day of 20 tonsils and I don't need a neuromuscular blocking agent. And yet I'll tell you that, there are some data out there that will say your incidence of perioperative respiratory adverse events is a little bit higher without a neuromuscular blocking agent. So I think if there's a scenario where, maybe the child's been ill or they have a history of asthma or there are other risk factors where the stimulation of laryngoscopy might set it off, then, again, I think we need to consider using a neuromuscular blocking agent. But, yeah, and again, like Dr. Fox said, I kind of use a, maybe 30 kilogram cutoff, because I think above that, these patients are more like an adult, where we, at least from what I remember from my adult practice, which is now at least 14 years in my distant past, would always use a neuromuscular blocking agent before we instrumented the airway. So, yeah, I think I use less neuromuscular blocking agents now than I used to. I think I'm a little more selective on who would get them and who wouldn't. And we won't launch into the discussion, but I can't leave without saying I think we cut off those of us that use succinylcholine or not based on an age of 50. So those of us above 50, and I'm well above it, use a lot of sucks. But my young people never even mentioned the word succinylcholine. So that's an interesting also kind of change in practice that I've seen.
Yeah, but I think that the change in practice in pediatrics and the use of succinylcholine really has a lot to do with the black box warning, right? So, I mean, that played a major role in it.
Right, and we all know that may not have been based on good science, et cetera, but perhaps a topic for another time.
Yeah, no, that's true. It's funny how every 30 years or so we rediscover the obvious.
Yeah,
we didn't know about dystrophy and the use of succinylcholine or NH and all that. So, in patients who are generally healthy, pediatric patients, does the ASA status or the condition of their health contribute to your decision of whether to use muscle relaxants for intubation, for instance, or even for maintenance?
I think that more so than just thinking solely about ASA status, it's about comorbidities and the clinical condition in front of you. So, using it for the ASA 3 or 4 trauma patient that comes in and needs to be immediately intubated, absolutely. The ASA for CP neurologically devastated child coming in for procedure, you may not need it. So it really is more about the clinical condition of the patient in front of you as opposed to what their ASA status classification statuses for me.
Okay. Thank you.
Yeah, I would agree. I think a lot of our, whether we use a neuromuscular blocking agent or not, is driven by some of our surgical procedures. Again, the robotics, the neurosurgical ones, the ones that you have to ensure immobility. And for some of those, it's like, well, the patient's going to need the block for the case. We might as well start off with it after we've breathe them down with SIVO. You get your IV in. We just initiate the case with it.
Okay. So if you were taking care of one of these patients who does need to obviously intubated and they need muscle relaxation, you're both proponents of quantitative monitoring. What technology, I guess, first, what technology do you have available? And then what technology would you consider to be the ideal technology for your own practice?
Right.
Well, I think that, so of the quantitative monitoring technologies that are currently available, so there's 4 that we talk about, 3 that are currently available, just to give some background and context to this discussion. So mechanomyography is really the gold standard that we've looked at. That's where we've based all of our thresholds in terms of when we talk about adequate recovery as a TOF ratio of 90%. So that's mechanomyography, no longer available to us commercially. But commercially on the market, there are 3 modalities. So there's kinemyography, acceleromyography, and electromyography. Kinemyography and acceleromyography are kind of the same format in terms of you're using a piezoelectric sensor. For kinemyography, it's between the thumb and the finger. There's a little device, and you're measuring the degree of bend when you're stimulating a nerve and the muscle is contracting. And that's where you're getting your numbers for a TOF count or a TOF ratio. The acceleromyography is using the same type of sensor, but it's looking at tissue acceleration of the thumb. Both of those technologies are going to be dependent upon free movement of the thumb. And so if you're in a case, as we're kind of talking about robotics and things like that, where arms are tucked under drapes, not the best technology to use. EMG, in my opinion, for pediatric practice, because regardless of it's a robot case or not a robot case, the majority of kids are going to have their arms tucked. And that's simply because if you have arm boards out in a tiny little patient, the surgeon can't get around the arm board to reach the patient. So by virtue of kids all pretty much having their arms tucked, EMG for me becomes the technology of choice, because it's measuring in the way it works, measuring compound action potentials and electricity rather than motion. So we can tuck the arms and we can still get a signal. It's also kind of nice, I think, because we're not having to fish under the drapes to look and feel and touch and all of those different things. So it's nice in that respect too. But I think for pediatric practice, in my opinion, that's the technology that gives you the most bang for your buck.
Yeah, I would totally agree. I think especially in the smaller patients, once you get down to 15 and 20 kilograms, some of the devices that require free movement of the thumb are somewhat difficult to apply to a smaller patient. And then again, I think a lot of the cases where we're monitoring, we don't have access to the arm. So cardiac surgery, robotics, some of the complex neurosurgical procedures, the kids are wrapped up, the arm is tucked. And at times it's like, okay, you're going to have one free extremity that you can really look at. Maybe your art line, your IV's already there. So you have limited real estate. And so I think having a device that, you can put on any of the 4 extremities, it doesn't have to really have free movement of the motor groups that are being neurostimulated. I think it's very helpful. And so for me, I think at least what I've found the last year or two is that the EMG-based devices may be the way to go.
Yeah, thank you. You mentioned something interesting, that you said you can use electromyography in any of the four extremities. So, in what case would you not use the arm, as it's at least for the adults, right? The ASA guidelines specifically recommend the use of the adductor pollicis at the thumb. But if that's not available, or if you cannot use it, there are alternatives. What are they?
Right. So we, again, it's, I think, this area where we need a lot more research. So we're currently finishing up a study comparing the arm, the standard monitoring site, to the foot, to see, because I mean, we really don't know, are these equivalent sites? Are there subtle clinical differences? I mean, I think we learned our lesson when people tried to stimulate the orbicularis oculi, and we kind of learned that, oops, no, that really doesn't work. So I think there's a reason the ASA guidelines. I mean, again, you got to look at good evidence-based medicine, and there isn't much out there other than the adductor policies. And so I think this is an area of good fodder for research, and something we should look at. But I think especially in kids, we may have limited real estate with the upper extremities. And, when I'm doing a neurosurgical case and I'm turning the bed 90 degrees, you never know, in the middle of things, if that monitors, you might need to adjust something. And so I think having it at least in an extremity that's close to you is nice. And so if I've got, an IV and an art line, in the arm, then maybe we'll put the device on the foot, the one that's closest, so that we can, get at it without, God forbid, interrupting our surgical colleagues. So.
Yeah, and I think that unless you take care of small babies, you don't realize that one IV on the hand can cover up the entire, from the fingers, to the forearm, just with the dressing that goes over that IV. And so limited real estate is a real thing, especially when you're talking about small babies. And we had a little neonate come into the operating room the other day that did have IV in the foot. And so really the only place left was one remaining leg. So you go where you can. And sometimes they just are covered.
Yeah, no, that's very interesting, and I agree with you. I look forward to learning more about the relationship between onset, depth of block, and recovery in these different sites, because it makes sense actually that different muscle groups will have different pharmacokinetics, right? So the question is, can you predict with some sort of exact time when it's the right time to intubate or to administer reversal or extubate, depending on the muscle group that you're examining? So yeah, that's really good work. I look forward to that. One of the things that I keep hearing, and I've actually had residents come to me and say, we don't need no stinking monitors. This vial of Sugammadex is the perfect monitor, right? Because you give it and you don't need to monitor anything, because the patient will magically be adequately reversed. What are your thoughts about the use of Sugammadex and its impact on quantitative monitoring, but more importantly, the impact on outcome in residual block and all the other potential postoperative complications?
Yeah, I think that's a great question. I think I was an early adapter to using Sugammadex. I think, I have no financial investments or disclosures for any of these companies. I think it's a game changer in the field of anesthesiology. I think they're controversy about the price, etc. But I think it's interesting to me that it's probably the only medication, or one of the few that we have, where dosing is based on a physical monitor. I mean, if you look at the package insert, 2 per kilo for this, 4 per kilo for this, 16 per kilo for that. Pretty broad guidelines, you know. And we're kind of sloppy with it in kids, because you open up that vial and you got so much left over. It's like, well, let's give 4 per kilo, you know, and be safe. But I think if you're really looking at, okay, how can I save costs in the operating room? I think monitoring may be a way. And I think there's some good preliminary studies coming out showing that if you're really monitoring to the train of 4 ratio and reversing based on that, that there are patients that maybe need 1 per kilo instead of 2 per kilo. And certainly if you're just one of those groups, kind of like ours here, where we give 4 per kilo to a lot of patients, that you don't need to do that. Now, what are you going to do with the rest of that vial? And I think there's kind of a push, at least in some places in peds anesthesia, to get the company to make a smaller vial, or even to have pharmacy compound your vials into 50 milligram aliquots. And we've done some pharmacoeconomic work to show that that's a very viable option to save some money. But I think you can only do that if you then have a means to ensure that, because nobody says 1 per kilo of Sugamidex, you know, the minimum dose is supposedly 2 per kilo. But I think with, you know, a quantitative monitor, you can document what your train of 4 ratio is, and maybe you don't need the bigger doses.
Yeah, I would absolutely agree. And we actually have done some work looking at that. Our pharmacy does aliquot into 50 milligram increments. And it's interesting because we have quantitative monitors currently in all of our anesthetizing locations. And when we started aliquoting Sugamidex, you know, people have to remember that the dosing of Sugamidex is based on quantitative monitoring at adductor. So just kind of randomly grabbing out of the air, I think this kid needs 2, or I think this kid needs 4, really is just kind of a guess. So it's interesting to me that folks, when we first implemented that, they would call me and say, oh, so this is saying my TOF ratio is 93%. So I don't have to give any Sugamidex? And I would say, no, you don't. don't crack a vial. Don't get a syringe. You're doing fine. And so there was that hesitancy, like we have to give something, even from the outset. I mean, that's a just kind of an educational or psychological barrier, I think, that people have. Like, I need to give some reversal. And on the flip side of that, are the folks that go, I don't need that monitor, and I don't need to reverse this patient because I gave them 1 dose of rocuronium 3 hours ago. They're fine. But interestingly, especially in kids who handle drugs very differently, I mean, there's inner patient variability to begin with, but there's also that variability through development about how they're handling those drugs as the volume of distribution changes. And so, you know, I've had folks call me and say, your monitor's not working. And I'll walk into the room and I'll say, okay, what's going on? Well, we gave the rocuronium 3 hours ago, and this monitor is showing me nothing. It's not working. And I said, well, you know, you got a 1-month-old baby in front of you. Maybe that's real. Maybe they really still are weak. And we can do a couple of other things. And we put actually in this instance, we put a peripheral nerve stimulator on the baby, which we know overestimates recovery, and saw 1 post-tetanic count. So we said, oh, you know what? That baby actually really is that paralyzed, or that. So just got to wait it out. And sure enough, we waited it out, and we got a post-tetanic count back on the quant monitor, and went from there. But the idea that also is very ingrained in people is that I know how much I give. I know how it should be gone over time.
Yeah.
which also is incorrect. So I think just a lot of it is education and understanding those concepts.
Yeah, no, really good points, and I think that the literature really is replete with cases where you have. I have to mention one study that has really made a profound impact on me in understanding the patient variability. There was a study done by Ron Katz back in the 60s. You guys are probably not old enough to remember this study, but he took 100 patients and he gave the same dose of curare on milligram per kilogram, 0.3 milligrams per kilogram, to 100 patients, and measured the effect that this one dose had on neuromuscular function. And 7% of patients had 0% block. So they're normal after this curare. 6 patients had complete 100% block. And the majority of them, 30% or 40% of them, were somewhere in the middle. So this really reminds us of the tremendous patient variability. You can't give the same dose to 100 patients and expect that every single one of them is going to react the same way. You can't give a dose and say, 3 hours later, rocuronium or cisatracurium is gone and all that. So I think that's a really, really important concept. Now, if let's say that I'm a clinician who really has not had a chance to use any of the quantitative monitors, what's the best way to even do that? I mean, what do I need to do to start adopting this into my own practice, other than obviously buying a monitor?
Well, yeah, you have to have access to the monitor. That's step one. But even having access to a monitor, I mean, there are multiple surveys and studies that have shown that even if you have access to a monitor, you may not reach for it. It could be just because of this really ingrained, I think, idea that I am clinically good enough and smart enough to look at the patient in front of me and understand if they are still weak or not. And so I think one of the first steps, even before getting the monitor, is just kind of a shift in culture and attitude in terms of how we approach patients and understanding that we can't see that weakness. And even with a peripheral nerve stimulator, if that's all you got, please put it on your patient. But that will overestimate what you're seeing in terms of recovery. And you cannot subjectively understand that TOF ratio. So unfortunately, when we're putting those on and we're looking for fade, which is telling us whether or not patients are still weak, you can't detect that with the eye or with the hand if you're doing a tactile evaluation until that TOF ratio falls to 40% approximately. Yeah. So in that window of 40 to 90%, and if Myron were here, he would say, you're just flying blind. You can't tell. So I think understanding that and really embracing that concept will help the adoption of quantitative monitoring, and knowing that any monitor that you use, there's a learning curve, and there's a troubleshooting kind of mentality that has to come along with it. So my folks here that are using it, when they have issues, they'll call me. But I also know that some of them will try once, and if it's not working right for them, they're like, this is not worth my time, and they'll put it aside. So a lot of it is cultural, an individual approach to the change.
Yeah, I would totally agree. I think, obviously you have to have the monitors available. I think you have to become facile with them, and it's new technology, so using them frequently is really helpful. I think there's a mindset too. I mean, I love have trouble with my cell phone and my computer. I love technology. And so, I think back, to the days that we were talking earlier about you had to get to the OR at like 4:30 in the morning so you could get the pulse oximeter for your room or the Dynamap. I started my anesthesia training in 1986. So, and yet there's no outcome study that shows pulse oximetry really improves outcome, but none of us would practice without it. And tidal CO2, and tidal gas monitoring, these things we all take for granted, that are gone when we, work in developing countries sometimes. So this is another monitor. There's just always a lot of emotion about new monitors because nobody's saying that your patients aren't doing well, that you're not doing a really good job, because I think we all are. I think it's just another device. I mean, I use depth of anesthesia monitoring. I use cerebral oximetry. And to me, this is another device that gives me more information about my patient. But I would say if you want to start using it, I think, try it on some longer cases where you're repeated dosing, where you're using infusions. When we use the monitor, there's still a little performance pressure. You're getting the kids to sleep, you're trying to get the monitor on, you're getting your IV, and it's like, somebody's given the neuromuscular blocking agent before you've got your baseline on the monitor. So I think use it for a longer case. We've got a study coming out where we looked at, can you place the sensor for the EMG-based device in the pre-op holding area, and as you might imagine, if the kids are less than 5 or 6, they're going to pick at it and pull it off. But maybe you can put the monitor, part of it on, and then once you get in the OR, you just have to plug and play. So these things, I think that way, because you're going to use the monitor, I think you have to have the glory of seeing the baseline and watching it go away with the neuromuscular blocking agent. And then you're going to learn that, hey, this really works. You're not going to have a case where you hook the monitor up an hour after you gave the blockade and you're like, oh, it's not working. Well, maybe your blockade's working. But I think it's really good to be able to see the baseline and watch it go away. And to me, that at least got me kind of geeked up about the EMG-based monitors.
Yeah. Okay. I mean, these are really helpful comments. And as you said, the best way to start is just by starting. Go ahead and monitor. One of the we've talked a lot about the operating room for obvious reasons, but do you think that there are other areas in which neuromuscular monitoring could be helpful or should be used?
Yeah, I mean, I still work in the ICU, and I think, again, that's an area that nobody's looked at. I think we have incredible problems with qualitative monitors in the pediatric ICU. Edema, poor attachments, people are unfamiliar with the devices, to the point where people, recommend these holidays from use of neuromuscular block in the ICU, where you turn the infusions off until the patient's moving, which can be kind of dicey because if the patient's on a neuromuscular blocking agent, there's usually a pretty darn good reason for it. So I think that in the ICU setting, there are several applications where I think, having a great judge of where you are with neuromuscular block would be incredibly helpful. Patients with underlying myopathic conditions, documenting you're ready for extubation. And I think that's a whole field that's kind of been ignored, where we've seen probably more problems actually from prolonged use of neuromuscular blocking agents.
Yeah, I would agree. Those populations that are receiving infusions are really tricky, kind of as was discussed, even using infusions in the OR. So that our ICUs typically have those kids on infusions, and that can be great to help guide them in terms of the level of dosing that they need.
Yeah.
Yeah. Great. Thank you. We talked a lot about electromyography, and not everybody's going to want to have electromyography or has electromyography. Deb, you mentioned that there are other technologies like AMG. So, can we, for just a couple of minutes, discuss the pros and cons of AMG, and particularly about calibration and normalization concepts and why we have to do those?
Yeah, absolutely. So, and I have predominantly used EMG. I have some experience with AMG, not necessarily clinically, but I've used it for research purposes. And for anybody that's used a TOF watch before, who may be on this call, you know that they're very finicky, like they're hard to use. And so I can see where adoption of that in the past might have been difficult. The current AMG devices that are available have done a lot to try to get rid of some of the issues that the previous models have had in terms of calibration, signal to noise ratio, those types of things. The thumb moves not just in one direction, but in 3 directions. So there are now 3D sensors that can help take out some of that noise. And the calibration issues, I think, the reason for calibration is to kind of set what your super maximal threshold stimulation is going to be. And most of the new devices, I think, just automatically default to 60 milliamps on there. So you don't necessarily, from my understanding and from a busy clinical practice, going through that setup can take some time, and it's going to be, I think, another barrier to people implementing that in their practice. So probably from a clinical standpoint, you can go through without the calibration because it's automatically going to set you to that maximum stimulation. But with the newer models, and some of them have gotten rid of some of the startup issues, the problem that we have with AMG is this tendency it has to overshoot 100% at baseline. And so when we're talking about recovery to a TOF ratio of 90%, if you're starting baseline, and this is why it's really important to put those monitors on and get that reading before you push any neuromuscular blocking agents. If your initial reading is 140, 90% is not going to get you to recovery. You need to have 90% of whatever your baseline was, so 90% of 140, which is going to put you up over 100 on that reading. So that's one of the finicky things about accelerometry, not well understood. I think some of it has to do with thumb position and returning to the same position every time that contributes to that. But EMG doesn't necessarily have that overshoot, at least not to that degree. There is some variability with EMG, but you don't tend to see that 130, 140 level at baseline. So those are differences between those two modalities, but certainly folks, I think, like AMG just for the maintenance and the cost perspective, because those units will tend to use EKG stickers for delivering the electricity, whereas the EMG monitors do have specialized sensors that come with them that are a recurring cost. So.
Yeah, I think we previously talked about the concerns with those monitors. You have to have free movement of the thumb, limited use if the arms are at the side. And I think, in between patient sizes too, it may be difficult to attach to, the broad range of pediatric sizes that we see. And obviously, again, the ASA guidelines are clear. It's, upper extremity adductor policies monitoring, but if you want to monitor at the foot, these devices are, can't be used.
Thank you. I don't know whether we have covered, I think we have covered enough territory. I wanted to leave 10 minutes or so for the audience to ask any questions of the panelists. I think it's a unique opportunity to talk to some real clinical experts in this.
Yeah, absolutely. And there's folks have been sending some stuff in. And again, guys, just use that private chat there on the right or the chat on the right to send a message in, and definitely will ask of the panel. But I have several that actually come up, a couple comments as well. I think Dr. Tobias, you touched on this, but somebody commented the overuse of neuromuscular block in the age of Sugammadex, and it's kind of the easy button, so to speak. But you guys, is this tend to be a pretty common practice that you guys see? Is that it's just you have this safety net now, and the overuse of neuromuscular blocking drugs is definitely an issue.
Yeah, I think we have gotten sloppy. I think one of the studies I really want to do is to look at how much rocuronium we gave before we introduced Sugammadex in my hospital to how much we use after, because I think we're not quite as careful with titration of doses and things with rocuronium. And, I think, again, Sugammadex is a great drug, but I think dosing of it is based on your train to 4 ratio. So I think although it's a safe drug and the incidence of residual paralysis is significantly less than with neostigmine, that doesn't mean we don't have to monitor those patients. But I hear that a lot, even at my own institution. So, I think that is maybe a misconception, I think.
Great. One of the other questions that came in, particularly around the role of quantitative monitoring with the use of succinylcholine during RSI, the need for it. Is there a need for it? Your thoughts on that?
So, the potential contraindications for use of succinylcholine in pediatrics notwithstanding, I think that if you are going to, I'm in a love-hate relationship, to be honest with you, because I love not what people say is the speed of onset of succinylcholine, although that's unquestionable. To me, the real advantage of succinylcholine, again, I'm speaking from the adult side, not necessarily from the pediatric side, it's not the speed, but it's the reliability. If you look at the number of outliers after your dose of 1 milligram or 1.5 milligrams per kilogram of succinylcholine, the outliers are going to be somewhere maybe 60 or 70 seconds. 80 seconds at most, but you're not going to have outliers at 3 minutes. You do have that even with 1.2 milligrams per kilo of rocuronium. So when you look at the mean onset for high dose 4 times ED95 of rocuronium versus succinylcholine, the mean onset is going to be similar. To me, is the lack of these outliers from a patient safety perspective that is really critical. And that's why, I love succinylcholine, but I really, really hate all the side effects associated with its use. So that's where I stand on that. I don't know if things are different with pediatrics, and I don't know whether you use succinylcholine for rapid sequencing pediatrics.
I will use it if it's truly indicated. It's interesting in the age of Sugammadex that I think most folks will use ROC because they know that they can quickly antagonize it if they need to. Even for, airway things where you're concerned about difficult airway, you can give a slug of Sugammadex and regain spontaneous ventilation, perhaps faster than you could waiting for succinylcholine to wear off. So I think that regardless of the black box warning and all of those different things, that most folks, at least where I work, use rocuronium rather than succinylcholine.
Yeah, I think it's, in my practice, it's an age thing. I think, and that's not a bad thing. It's just the younger people, I think, have grown up with the black box warning and things like that. And again, you have to follow the guidelines for when sucks is indicated. But clearly potentially difficult airway, rapid sequence intubation. And I agree with what Dr. Brohl said. I think, when you look at the mean onset times, yeah, they're going to look pretty similar. But boy, when you look at intubating conditions and you look at outliers, I still think SUX wins in the right population. Again, the undiagnosed myopathy is the one that we all worry about. Patient with hyperkalemia, we're not going to give SUX. Renal failure, maybe you avoid. The myopathic ones, you definitely do. But I think that having a monitor, helps with the rocuronium issues. And so I think if you are holding on to rocuronium because you don't want to use SUX, which is fine, use that 1.2 mg per kg dose, and then you can watch your onset of rocuronium. I kind of click my watch and go at 60 seconds, or I used to. It's probably not a good way to say when you should start your laryngoscopy. Maybe having a monitor that really shows that you are blocked is the way to go. And I think the whole, can I reverse with Sugamidex if I get into trouble with rock? I think, the European guidelines are going to remind you absolutely not. It just doesn't work. And in fact, their difficult airway guidelines don't even recommend the use of Sugamidex because for a host of reasons. One of them is that it may take you away from what your real focus should be in a can't intubate, can't ventilate scenario. Not that SUX is going to wear off any quicker and get you out of trouble. So I think that's always a good thing to think about.
Yeah, and I think that when people talk about reversal of high dose rocuronium with high dose Sugamidex, forget to think about all the 300 mics of fentanyl and 4 milligrams per kilogram of propofol that we have given, and you have full neuromuscular function return, but the patient is not breathing. Guess why? It's probably because the monitor doesn't work, right?
Awesome. Excellent. Well, that about wraps it for us because I want to be respectful of everybody's time. Thank you, everybody, for joining us. Dr. Folk, Dr. Tobias, Dr. Bruhl, thank you so much for doing this. Very enlightening, and I think this will be very beneficial for everybody who was in attendance and everybody that watches later down the line. So thanks so much, everybody, and have a wonderful, wonderful, wonderful afternoon.
Thank you.
Thanks, everybody. Much appreciated.